All right. Good morning, everyone, and thanks for making the time to come along and speak and engage with myself. And today's guest is Will Egan from Ods Med, which is a online CPD continuous professional development and education platform. So without further ado, I'm going to get Will into the stream, and we'll have a bit of a chat and talk about CPD online and upskilling with remote healthcare workforces. G'day, Will.
Good morning. How's it going, Yianni? And good morning, everybody.
Fantastic, mate. Really good. Look, I wanted to get you on the show, obviously, to talk a little bit about, I guess, there's a lot of transformation happening in the industry at the moment. A lot of people have been pivoting away from doing full-time in-clinic services and practice-based services, and now starting to work with their teams from home using video, telehealth type concepts, or perhaps even being itinerant, but using their home as a base. So I thought it'd be good to sort of talk about what you've been doing at Ods Med and some of the great online CPD modules that you've got going on, and in particular the Teams learning module that you've got going on. So we'll sort of break it down over the course of this live stream. Hopefully we'll get a bit of engagement. If you want to ask Will any questions, feel free to ask a question in the comments section, and we'll do our best to pop those up and put them to Will, and hopefully get you some answers on there as well. So just getting straight into it, Will, tell us a little bit about your good self and Ods Med.
Yeah, absolutely. Well, thank you for having me on the show. So I guess the first thing to say is my background's more on the software side of things. I'm not a clinician. However, I've been married to a nurse now for a while, and my wife and my mum are both nurses, grown up in the kind of in the healthcare space, and have been at Ods Med for 13 years. So my work has really focused around building our software. So for those who are streaming might be using the Ods Med app. That was one of our first projects, started in 2009, helps health professionals maintain a continuing professional development portfolio as part of their AFRA and subsequent board's registration. Yeah, working from home at the moment. We're filming this during the COVID-19 lockdown period, and so proud of the Australian healthcare system in terms of the way everyone's and the community pulling together. At the moment, I think we're really seeing the effectiveness of our healthcare system, even though we do, there's lots of opportunities for improvement, and as there should be. You know, it seems to be holding up pretty well at the moment, which is really good. Yes, that's a little bit about me.
That's awesome, Will. Yeah, you've had a long journey with Ods Med. You're currently the Chief Strategy Officer. You've been the Chief Marketing Officer. You've been heavily involved. I know you've got a massive passion and interest in developing coding capabilities for our young people, and really promoting having those types of technical skills as well, and really embracing kind of the technology and health tech concepts as well. Do you want to share a little bit about what you've done over time in that area?
Yeah, absolutely. So I was kind of one of those unusual kids that liked computers growing up at school, and you know, built websites and things like that. And I didn't realize at the time that that was going to be a skill that I would actually use as in a career. You know, it was just fun and games. I built an online Pokédex, which is kind of like an inventory of your Pokemon, which was good fun. And yeah, I kind of look back at school after a few years after leaving, and saw that in fact only one other student from my year level had gone into programming and you know, anything IT. And I thought that was a bit strange, considering I think it employs over 400,000 Australians at the moment, IT directly. So a couple of old schoolmates across different year levels who'd done that, and I went back to our school and offered to teach coding as a code club, and that got great kind of feedback. It eventually grew into a national and then an international organization called Code the Future. In the end, we got coding clubs and helping not just clubs, but even working in the classroom alongside teachers. We were a platform that would help bring volunteer software engineers from the software development community at companies like AUSMED, Xero, realestate.com.au, car sales, places like that, Invato, into schools to work alongside teachers in the classroom to kind of bridge that initial knowledge gap between not knowing how to code and knowing how to code. In the end, we were successful in the sense that we were no longer required, which was always my kind of basis for success. I think it's such a core skill that schools shouldn't be outsourcing the provision of that knowledge, that they actually need to be able to provide it kind of by default, just like they do with science, maths, English, and other subjects. And in 2018 or 17, I think, the digital technologies curriculum came into play, which meant that it was mandated across the education sector that kids must learn coding. So it went from a voluntary thing to like a mandatory thing. And now kids are learning coding at school, which is great. So we helped about 120 schools across, mainly in Australia, but a couple throughout the world, as far reaching as Barbados, believe it or not, set up coding programs in their schools, which affected thousands and thousands of kids. And in fact, one of the kids I supported all the way back in 2016 is going to be coming into AUSMED to do an internship in programming after they've now finished a coding degree. So that's quite rewarding, but it no longer runs at the moment. It's been a kind of folded into the Department of Learning and Teaching Victoria.
Well, that's awesome, mate. Now, I think it's, there's those of us who've been working in tech for a long time. We kind of understand, the benefits of being able to work remotely and what type of tools to be able to use, and how to actually sort of create, I guess, a virtual workplace. Which is basically, the tech office is distributed. It's all over the place. It's every team member's home is an extension of the workplace. And so, when you're sort of thinking about how do you train and support and develop, how do you deal with things like occupational health and safety when you don't have everybody in the same place, where you can't sort of schedule the whole team to get together on, Monday morning at 9 o'clock and sort of work through the latest detail on how to actually, protect ourselves against COVID-19 or, other types of occupational health and safety issues that arise from time to time. So I wonder if you could sort of take us through, if we get sort of straight into the main event and talk about the AUSMED Teams module, because I think that's a real cracker for being able to deal with exactly that, but in the context of healthcare, as opposed to the kind of online learning tools that developers and digital marketers and technical people actually do. Talk us through that, Will.
Yeah, absolutely. So basically, and maybe I can provide a little bit of background to how does education actually kind of work in the healthcare sector. This is kind of my assessment of things. So I think in a nutshell, there's two drivers. Basically the government, we as the people vote in a government based on a set of policies around how they'll organize our healthcare system and the standards and services that we have available. And what the government then creates as part of that promise is a set of regulations that enforce or mandate certain standards must be met. So those standards typically are scoped into two areas, or I'm going to talk about just the two specific areas that they're scoped when it comes to education. The first is that that the organizations that people work for are providing education. And this exists in most accreditation frameworks, that there's evidence of ongoing learning. And then the second, so that's a kind of regulation against the organization itself. And the second is a regulation on the individual, which is through AFRA and the 16 national boards, and described as continuing professional development. And in a nutshell, that's the onus on the individual to do ongoing learning. Now, hopefully if both those bases are covered, the workplace is making sure education happens and the individual's making sure education happens, we have a continuous improvement process occurring around knowledge acquisition and application in practice. So AUSMED focuses on building software and content. So two things, software and content, that solve both those problems. So on the organization side of things, this is typically described as mandatory training, whereas for the individual, we call it continuing professional development. The mandatory training component, in a lot of accreditation instances, there's not actually a stipulation of the topics that need to be provided for mandatory training. It's more that it's occurring and that certain learning outcomes are being achieved. And in fact, in the general practice field at the moment, the board, my understanding, this is still a work in progress, but is reviewing the CPD standards for the individual GPs to say that there actually needs to be, demonstrable evidence that the learning that was taking place genuinely improved practice. And we're really good at articulating that on the individual side of things, but in the workplace, we're still a little bit checkbox when it comes to mandatory training. We had Donna Wright down in Melbourne in December, who presented at an AUSMED conference where she talked about, the mandatory training kind of educators going around just saying, like, I need to check you off my list. Have you done hand hygiene? I need to check you off my list. And actually missing the point that it's not about getting the list ticked. It's about, is this person safe and competent in their practice? And are there other ways that you can demonstrate that before just jumping to education? Education is more like an intervention kind of before or after the fact if you don't think the person's competent. But if somebody's known how to wash their hands for 10 years, 20 years, and been doing the same hand hygiene module for 20 years, is there really a need to get them to do it over and over and over again? Or could they perhaps test out of that training or demonstrate their skills to not have to do that, demonstrate their competency to not have to do that education over and over again? So we've focused on building the software and the content to enable that to occur. Our AUSMED for Teams offering is really interesting. It basically lets you describe your own mandatory training schedule, upload or link to AUSMED or external content that's anywhere on the internet, or upload any of your own resources into that learning management system or AUSMED for Teams. Assign that out to all your staff, report on whether that's been completed. It's such a seamless process that the people who use it are kind of both the staff. So this is kind of like, imagine an education program your staff actually enjoy, actually like to use it, and participate really well. But from a manager or a practice manager, from a service manager perspective, you can get very quick reporting on like who's doing what learning and who isn't. And even some of the barriers. So we go a lot deeper. Anyone who's used AUSMED's individual CPD portfolio would see the depth of analysis and self-reflection that we help health professionals undertake each time they complete learning. With AUSMED for Teams, we're able to surface some of those insights for the manager as well. So you might find, let's say, hypothetically, run through that workflow. You find a module that's fantastic in a given field, or it's the latest evidence in a given field that's relevant to your team. You upload it into AUSMED for Teams. You assign it out to all the individuals. They do all the learning. They reflect on the benefit of that learning. And then you're able to go back into Teams and look at how many people have completed it. There's your tick box. So we tick the box. We still tick the box. But underneath that, what you get is so many more insights, which is, okay, 80% of my staff actually said this was new knowledge for them, whereas 20% said it was existing knowledge being reinforced. Of the group that said it was new knowledge, 5 of them said that they're interested in further learning in this area, and 1 of them actually suggested a resource that we could maybe share with the rest of the team. Another 5 of that group that said it was new knowledge said that they think they're going to face a barrier when trying to implement it in their practice, and here were the barriers they identified. So you can actually start to whittle down and optimize through that learning process from kind of the collective all the way to the individual, making sure that each team member feels competent and safe and effective and able to actually apply the new learning into practice.
So, Will, as a practice owner, so effectively what a practice owner could do is actually not just have the teams managed in terms of their progress towards CPD objectives and any other kind of mandatory education that's needed within the context of delivering healthcare and running, I guess, the occupational health and safety side of things as well. But can we design it? Can we actually sort of say to ourselves as an organisation that we want everyone in our team to know certain stuff, and then we want individuals in our team to know that kind of, that core stuff plus some additional things as well? Talk us through that.
Absolutely. Yeah, absolutely. So you can definitely do that. So there's 2 kind of ways to do that. The first is you can create a mandatory training schedule or an induction schedule, which is common across all team members. And it's typically organized by job role. So you might say everybody in this job role needs to do these 10 things every single year or every 6 months, or on some repeatable program, we'd call that like a loop. some kind of recurring basis. The second way that you can allocate training is on an individual or as a group, but on an ad hoc basis. So it's a once-off, it's not recurring. And an example of that would be the COVID-19 training module from the Department of Health. You know, everyone doesn't have to do that every year, but everybody probably should do that right now or yesterday. So for that, you wouldn't use mandatory training, you'd use assigning CPD. You're able to just go in, discover that resource, and literally one button assigned to everybody. Everyone gets a notification. They can tap on that in their phone, open the app, go to the website, whatever it is, complete that learning. And as they're completing it, we're giving you a live feed of who's doing what education.
Excellent. And
really fantastic for remote teams as well.
Well, that's kind of why I thought it was a great opportunity to actually share about AUSMED right at this point in time, because whilst you know, video and an extension of video through some telehealth capabilities are probably the prominent thing that a lot of people are transforming and adjusting the way they're operating their healthcare businesses at the moment. The reality is that whether you're delivering healthcare remotely, online, in person, you're still a healthcare provider and you're still running the clinical governance, you're still running the business of healthcare. It just means that the modality, the way that we're actually delivering it, is not necessarily 100% of the time face-to-face as it's been up to date. And now it's being extended through, you know, video, through phone, through chat, as an example. And there are even healthcare workers who are itinerant. You know, they're moving from their home office out into the field and then back again, you know, and not necessarily coming back to the clinic or coming back to the healthcare setting that has traditionally been the case. So I think it's really important to understand that in addition to having a distributed team or distributed workforce in healthcare, dealing with the occupational health and safety, dealing with the professional development is still a part of the the ongoing running of the business, so to speak, and the compliance with professional bodies, with APRA in terms of registration status. So this is a great way to actually be able to do that. And you know, it's great that you were sort of bringing out how you could actually sort of personalize it to different people in the organization. You can be very responsive to right now stuff that we all have to know and learn and demonstrate that we have learnt it. So what about, can I create content? Can I actually create courses, so to speak? Or is AUSMED the only source of all the courses?
Yeah. No, so it's a great question. And just before I answer, I might just add a comment quickly to one of the things you said, and I think it's quite important. I think the you know, in any health service, you know, we're all familiar with this notion of mandatory training, and the reason why I talk about that is specifically the practice managers or the service managers, the people running the business of healthcare, as you say. You know, you get to an accreditation cycle and you see those elements in the accreditation and you think, yeah, like we are doing that, and you know, and you're able to tick the box, but everybody kind of is, you know, but it's not really the point. It's kind of like what we say with CPD, you know, doing 20 hours if you're a nurse or 30 points if you're a pharmacist. That's not kind of like great work. That's actually the bare minimum. You know, that's the lowest. Like anything lower than that and you're not compliant, it's not something to aspire to. And in fact, the average person using AUSMED's individual portfolio, which is we have about almost 40% of the health workforce using AUSMED's free portfolio to manage their CPD after 10 years of having that out in the market, does over 50% more than their mandatory requirement. Our view is that the same ethos could take place in a health organization, in a health service, if they were provided better software. And they could actually really trace back, just like every other part of their business, almost like an accounting exercise, account for the impact that education's having in their practice. And that's what Teams is designed to do. So it's designed to say, yeah, you tick the box, you get your 20 hours or you meet your mandatory training requirements, but like that, you do that kind of, you know, in your stride. That's not even a thing. You're actually much more focused on the dissemination and distribution and efficacy of the education that's taking place, and the participation from the broader kind of team. Everyone can contribute resources. So that's that. In terms of your specific question, there's 3 ways you can get content into OdsMed. First is OdsMed's library of resources, which is over 1,000 high quality resources currently. Over 1,000 is natively built in. You can browse through those and assign them. And if you jump across to online CPD, the menu item there, you'll see all those. And the second way is OdsMed has content partnerships with reputable publishers in the sector. So think groups like Blood Safe eLearning, COPE, Centre of Perinatal Excellence, the Health Department, the Dementia Australia, and National Prescribing Service. There's a list of them there. Maybe if you tab across to providers, Yianni, on the second menu, the one right at the end, you'll see, the second row down, you'll see that. Yeah, providers, you'll see the list there. So Health InfoNet is another great one, kind of the preeminent resource for Indigenous health resources. So all these resources are actually available natively within OdsMed. If you click on the Heart Foundation one, for example, you can actually just assign those resources directly to your staff, or they can discover them. And when they click on those, we'll take them directly to those websites, kind of deep link them right to the right location on those sites. Sometimes it can be a bit hard to find the great content that's there, so that people can complete that learning. And most of that's free as well. There's a lot of free content out there, and we really try and expose as much of that as possible, and we make a lot of it ourselves. Over half of our resources are free as well. And then the third way you can get content is you can actually create it. We are building a course builder, but it's not live yet, so you can't create and publish courses in OdsMed yet. That's actually what we're working on this month, April. But what you can do is upload content. So even things like a guideline. So imagine creating a learning path where you basically upload a video that shows the latest evidence in X, Y, or Z. Maybe you're linking to it on YouTube. You can do all that. Then you can upload your own policy or guideline internally on that exact same process and show how it's been changed. And basically assign all of those out to your staff, and they can step through that learning path and kind of really complete the loop. So you can upload documents, PowerPoints, guidelines, Word documents. So, and in the future, be able to build those natively within OdsMed is what we're working on at the moment.
All right, so that means that we can design our own courses and our own modules to suit our particular business type. You've got a lot of content that covers all kinds of healthcare professions, ranging from mental health, physical therapies, nutritional health and wellness, nurses, midwives. You cover quite a spectrum. I mean, you've got a ton of content in there. With 1,000+ modules. And I notice you've also got learning hubs, you've got online courses, you've got videos from key people in the industry talking about educational type of content as well. So, but what I personally really love is that idea, because most people can go to Google, try and find the information themselves. So I think it's great to have a consolidated and concentrated place to get access to those free resources. And I love that deep linking type of idea. But above and beyond that, the idea that, in the tech sector, we use, tools like your Pluralsight as an example, which, if you want to actually figure out how to make adjustments in a DevOps environment, or, how to update your skills on React, for example, there's a bunch of sort of learning modules that our teams go through, which give us a view where they started, what percentage they're at in terms of completion, whether they've actually done. And we're actually able to fold those into their own professional development plans within the business as well. So I really relate to it that way. I like the way that
it's exactly like that. Yeah, it's exactly like that. And the only thing that's in addition to that is the self-reflection component, which is pertinent in healthcare, because we want to ask the question at the end of the day. Our CEO has this kind of 2-word challenge for anyone in the business that when they're working on anything at OdsMed. Especially our clinical education team, is so what? So what? You've made this, so what? Is it actually working? Is someone actually reading this, watching this, doing this course and changing practice? And self-reflection is kind of a stepping stone towards finding that answer out. and we're working on a few other kind of software solutions to really uncover that answer. But the self-reflection aspect is really important in healthcare, so that you can kind of reflect and say, did this learning actually fill the known gap that I have in my knowledge? And if not, like, do I even count it as CPD? Are the hours worth it? Maybe they're not. We have a lot of people who use AUSMED who might go and do 2 hours of education and say, I'm actually not going to claim that as CPD because there's no relevance or value to my practice. And they're not just focused on kind of getting their hours up, they're focused on kind of an effective, impactful learning, where the so what factor is actually present,
When we were talking recently, when I had you on the podcast, you were talking about some of the theory behind that self-reflection. Do you want to just give us a quick summary of that? Because I found that fascinating.
Yeah, so there's a couple of kind of principles that we like, known research principles, and maybe Yianni, hopefully you can share the diagram. So it's ASGEN's theory of planned behavior, and the problem for any education provider at the end of the day, it doesn't, face to face, even if there's an assessment, is we don't actually get to see the hands that touch the patient or client, and we don't actually get to see if the education genuinely or actually did change patient care. So this is a real challenge, because in our business model, that's actually, if we could, that would be the closing of the feedback loop. There was a problem, we applied education as a solution, and we saw the required change take place. Now, clinical education managers, business owners, practice managers, they can see that. And that's where Teams provides them with the software to kind of record that, and self-reflection is a key part of that. But for the individual, at the moment that they've finished learning, their problem is that they haven't actually had a chance to change their care, their way that they provide care yet. They're only just finished the learning 5 minutes ago. So we built a self-reflection tool that uses this theory of planned behavior as its kind of basis. It's all research-based. We actually published an article in the Journal of Nursing Continuing Professional Development in the US, and this specific article was awarded the CE credit for that issue of the journal. And what we basically said is, if we can help a learner immediately after they've done learning step through ASGEN's theory of planned behavior, which basically says that as long as those 3 things you see on the screen on the left-hand side of this diagram are present, attitude, subjective norm, and perceived behavior control, as long as those 3 things are present, the learner can at least form an intention to change practice. And an intention is a good indicator as to whether the behavior will actually occur and whether they will actually change practice. So we can measure intention. We can't measure change, but we can measure intention to change. And that's what our self-reflection tool is designed to help the learner step themselves through. And these 3 boxes you see on the left, attitude, subjective norm, and perceived behavioral control, are really important. What they basically say, and I will use the example of the gym, is first attitude. Does the individual have a positive attitude towards the behavior of exercising and getting healthy? And if the answer is yes, then that's something that's in their control, and that's a tick. Then we move to subjective norm. Do they perceive that others believe do they think this is a normal thing to do? Like, it's normal to go to the gym, it's normal to eat well, it's normal to stay healthy. If it's a yes, then that's a tick. So we've got 2 out of 2 so far. And then the third is, if you could just bring it back up, this is the one I always forget, perceived control. Yeah, perceived behavioral control. Is this something I can actually control? So I know it's good for me. I know others think it's good for me, and it's good for them. But is it something I can control? And it is. In the case of the gym, I can actually change my behavior and start going to the gym. So if all 3 things are present, if all 3 of those things are present, then the person's able to form an intention. Once an intention's there, they're far, far more likely to actually change their behavior. In healthcare, that third part typically becomes, in a bad culture, the second part is what's the problem. Subjective norm. I know this is the latest guidelines or evidence, but no one else does, or they don't care. The subjective norm is, well, why would we change? We've always done it this way. Why would we do it the new way? We know the old way works. And that suddenly becomes the barrier to the intention forming. But commonly as well is perceived behavioral control. And I remember seeing this with Code the Future in the schools. It's common in healthcare as well, is because the system's so large, people don't feel like they have much control over how it operates, especially individual clinicians in any given service, on a telehealth call, on a ward, on an ICU ward, in the community. They're kind of running the system. They don't feel like they can change the system. So perceived behavioral control often becomes the main barrier. And there's lots of ways that presents or manifests. But people could then use this self-reflection as a way to actually identify further knowledge gaps, and look at how do we restructure the organization such that there is more control at deeper levels, the individual staff levels, or other ways to do that as well.
That's fantastic, Will. So I guess just finally, surviving an audit. What can the subscribers then to AUSMED do in order to respond to APRA, respond to a professional body or any other kind of audit? Talk us through that, because I think that's a really important part of all this.
It's a good question. Yeah. So we'd call that like an extrinsic motivator. A lot of people are intrinsically motivated to do education because they see the benefit of that to their practice and their patients, clients. But the extrinsic motivator is obviously it's tied to registration. Having said that, AUSMED was around for 30 years before, say since 1987. So what's that? Almost 20 years before national registration and mandatory CPD came in place. So you'll be pleased to know we're not it's not a cynical situation. People do enjoy doing learning. There's a lot of people who are learning for a long time before it was made mandatory. And that's why we say that kind of 20 hours in the case of nursing, or 30 or 40 points or whatever it is the bare minimum. Now, in terms of the audit with AUSMED, by using AUSMED, we don't guarantee that you will pass an audit. There are lots of ways that the respective boards, will evaluate whether you're meeting all of your regulation requirements, all of the standards of practice. One of as many standards, 3, 4, 5 in some cases, and one of the standards of practice. So things like recency of practice, professional indemnity insurance is a standard of practice. Police check is having a right to work. I can't remember that one exactly, but is a standard, and CPD is also a standard, maintaining your continuing professional development. Now, in the CPD standard, there's not last time I checked, a published framework for how the board, any given board, will audit a practitioner. What we do know is the vast majority of people who use AUSMED seem to have no issue passing an audit. Now, our view is, imagine we give you a blank Word file, a Word document on your phone, and we step you through a process to fill in or provide all the information you might be needing to provide if you were audited. As long as you're using that properly, it'll take you a long way. But some of the so if you are audited in AUSMED's free CPD portfolio, you can log in, download a full PDF summary of any of the last years that you've documented. You can have the last 10 years, 20 years in there if you want to go and backdate it, and some people do. But often you might be asked for the last 3 years of your personal records. In an organization as part of accreditation, you might be asked for just the last accrediting cycle, or if it's an audit, kind of a spot check. And you can generate that data, within 30 to 60 seconds in most cases. Certainly on the individual side, you can get that, in 10, 20 seconds. Attach it straight to an email from your phone, forward it to yourself, print it off, or just forward it straight onto whoever is requesting the information. Our view is that you don't do education to pass an audit; you do education to improve patient care. If that's where the software comes in, and the software really helps make sure that you're dotting the I's and crossing the T's, and it's designed that way. For example, you can't actually record learning in AUSMED if you don't do a reflection. So we force you to do things that we know auditors will require if you are audited, so that you're not kind of misstepping along the way. And we hear all the stories, and maybe you've experienced it yourself. You're audited and you've got to take a week off work to collate the last 3 years of evidence, organize it. We get the calls, AUSMED gets the calls. Can we send certificates here, there, and everywhere? your workplace, you might call them, ask them for certificates or copies of records, but the boards have always been very clear that the onus to maintain a record of learning falls with the practitioner, not with the organization. And unfortunately, a lot of those organizations, once you leave the workplace, don't actually have access to those records anymore and might not store them. So it's really important to own this information yourself, to try and document your learning as you do it, so that you're ready for that spot audit. We hear many stories almost every week of people who get audited and felt like they had their content ready within a minute. They're like, no worries, I've got this. Forwarded on, a couple of weeks later, all good, no questions asked. The one thing that we hear often being scrutinized in particular is this language, education that's relevant to your scope of practice. So often what we have seen is people have done education that the board may deem is outside their scope of practice. Imagine an aged care nurse doing pediatrics learning, just a really trivial example, or just kind of pretty binary example. The board coming and saying, that's not in your current scope, you can't count that as CPD. And then saying you need to do an extra 10 hours in the next 3 months, for example.
I've helped many clients over the years of Core Plus when they've gone into that kind of panic station around audits and needing to kind of bring together documentation. So I think the key thing is there that when it's contemporaneous and when the way you've set up the system to be able to do the the planning, the scheduling, the management of it, the reflection, and then being able to actually document that, that in of itself is just huge, to be able to actually just click a button and get all of that information all lined up. That's fantastic, Will. Well, just wanted to wrap things up there and say thanks for making the time and coming to talk to us about that. I think it'll add a lot of value to people who are listening to this to be able to sort of say, well, how can we actually now run a virtual team, a virtual workforce, and whether that continues to persist beyond COVID-19 response or not. I mean, if we're going to be working like this for 6 to 12 months, as an example, it's going to be key to be able to deal with the normal business aspects of running the healthcare business. So hopefully people will get a ton of value out of that and really understand it. Just generally, if you want to be notified of upcoming live streams, we're going to be talking about all sorts of subject matters in and around the reimagination of healthcare and how we actually translate from the way we used to do things to the new normal, so to speak. On we're not just going to do things for a couple of months and then just sort of snap back into the way things were. There's a lot of change happening now that will persist and be permanent at various degrees of scale. Subscribe. Sorry, Will?
Totally agree. This is like a shot of adrenaline into the system, and there's just a lot of step change happening everywhere that'll be permanent. Totally.
Yeah, it seems like it's sort of a hyperactive kind of period, but then we'll sort of settle into the new way of doing things going forward and what have you. But we're going to be live streaming and leaving the recordings on our YouTube channel. So you can subscribe to that and click the bell for notifications, and the same with Facebook video as well, by liking the page and ticking the notifications as well. So on that note, I'll say thanks to everybody for participating. Will, thanks very much for coming along and sharing your passion and knowledge around software and people through the learning cycle of professional development. Really appreciate it. Thank you, Will.
Thank you so much for having me, Yianni, and thanks everybody. Have a great day.
Absolute pleasure. Speak to you soon.
Cheers. Thank you.